Hello and good evening, everyone. Welcome to our 104th Blades virtual seminar. Blades virtual seminar is a platform that allows healthcare professionals to discuss current management updates of different health-related topics for better patient care. And this platform is brought to you by Blue Health Ethiopia in collaboration with Lifeline Addis. So Blue Health Ethiopia is a medical consultancy company founded by medical doctors and a computer engineer, and we aim to be an influential healthcare leader in creating a skilled community through easily accessible knowledge and preventive medicine. And I'm your host, Dr. Iheno Tadela, a general physician and first aid trainer from Blue Health Ethiopia. It's a pleasure having Dr. Esrom Hagos here with us to have a seminar on approach and the approach and management of hypertension. So Dr. Esrom Hagos is an assistant professor of internal medicine at Wallo University and Dase Comprehensive Hospital.
Okay, thank you for the warm welcome and brief introduction about me. My name is Esrom. I'm currently working at Wallo University and Dase Comprehensive Referral Hospital as an internist. I'm also working at Lifeline at this home-based care. And so today's seminar is going to be on approach to management of hypertension. Hypertension is quite a vast topic, and it will be difficult to address all the aspects of hypertension in one seminar. So today we'll just focus on mainly on chronic management of hypertension. So this is going to be my outline of my outline, and we'll discuss on definition and how the definition came about, categorization of blood pressure, and the new categorization of blood pressure as well. And we'll also see blood pressure measurement and screening. And finally, we'll touch points on prevention and treatment of chronic hypertension. So the definition of hypertension has not changed for quite some time. It's defined as a confirmed office systolic blood pressure of more than 140, greater than or equal to 140 systolic, and greater than or equal to 90 diastolic. So studies have shown that demonstrate a continuous and linear association between blood pressure and adverse CVD outcomes. So another alternative diagnosis would be the level of blood pressure at which the benefit of treatment is overwhelmingly outweighs the risk of treatment. So using blood pressure threshold for hypertension alone, for the purpose of treatment alone, would lead to under treatment of many high-risk patients who don't exactly have this threshold blood pressure, but at the same time are at high risk for cardiovascular events. So another thing from the definition is that it has to be confirmed. Okay, so confirmation is required for with outpatient office measurement, either with home-based blood pressure measurement or ambulatory blood pressure measurement if possible, and if not, at least it's recommended to have at least one repeat office blood pressure measurement. So how should we categorize adults based on their blood pressure measurement? And is categorization recommended? So yeah, categorization is highly recommended, and it's a class 1 indication recommendation. So after we measure blood pressure, we should categorize those individuals. So we have 3 categories. The first one is non-elevated blood pressure. So basically, non-elevated blood pressure is either office, home, or ambulatory blood pressure measurement with a systolic of less than 120 and diastolic of less than 70. So what does this mean? So if an individual has non-elevated blood pressure, it means that studies have shown that there is no sufficient evidence and efficacy and safety of blood pressure pharmacologic treatment in this group of patients. So the second is elevated blood pressure. So we say an individual has an elevated blood pressure if the systolic blood pressure is between 120 to 139 and diastolic between 70 to 89 for office BP. Whereas for home and ambulatory blood pressure measurements, systolic between 120 and diastolic 120 to 134 and diastolic between 70 to 84. So if an individual has this BP measurement, we say that he or she's having an elevated blood pressure. So with regards to elevated blood pressure, the most important thing is this category of individuals need risk stratification. So if we find an elevated blood pressure, we should risk stratify to identify individuals with high risk cardiovascular events and benefit of pharmacologic treatment. So in this group of patients, we have two groups: one that require pharmacologic treatment on top of lifestyle measures, and a group of patients who only require lifestyle measures. And last, we have hypertension. So hypertension, as we discussed above, more than 140 by 90 for systolic and diastolic respectively for office, but for home and ambulatory BP measurement, we say hypertension if systolic blood pressure is more than 135 and diastolic is more than 85. So this group of patients, they already have a very high risk. So that's why we don't need to risk stratify this group of patients for pharmacologic treatment. So having this threshold of blood pressure already puts them at a high risk for cardiovascular diseases. So cardiovascular risk is sufficiently high to merit or to warrant BP pharmacologic treatment. So another point is that we should avoid previous terms such as normal BP, optimal BP, or normotension. So these are more or less more of a prognostic word. So we should label based on these three categories. So as we said, the second category, elevated blood pressure, needs risk stratification. So what do we mean by cardiovascular risk stratification or assessment? So total cardiovascular risk is the likelihood of a person developing cardiovascular event over a period of time. And hypertension rarely occurs in isolation. So most patients will have other cardiovascular risk factors such as dyslipidemia or glucose intolerance. And more than 50% also have other cardiovascular risk factors. So the European guidelines, like European Society of Cardiology, recommends to use a systemic coronary risk evaluation score system. So this group of patients should be scored. So this is an algorithm on how to approach patients with elevated blood pressure. Again, BP between 120 to 139 and diastolic between systolic and diastolic between 70 to 89. So if we find a blood pressure measurement in this range, the first thing to do is we should look for other high-risk conditions. So what are these high-risk conditions? Like if they have already established cardiovascular disease, meaning if they have stroke, coronary artery disease, peripheral arterial disease, and whether they have moderate to severe CKD, or whether they have hypertension-mediated organ damage, DM, and familial hypercholesterolemia. So elevated blood pressure in the conditions that I just mentioned together would make an individual to have a very high risk. So this group of patients would need intervention. So the intervention could be lifestyle measures, and if those lifestyle measures don't work, then we go to pharmacologic therapy. And for patients with elevated blood pressure but don't have this high risk conditions, we have to calculate their score. Okay, we have to calculate their risk. Okay, so we can use different scoring methods. So the score 2 and the score 2 OP meaning for older patients, for patients above the age of 70. We can use that to calculate their 10-year cardiovascular risk. So elevated blood pressure and a 10-year cardiovascular risk of more than 10% puts an individual at a very high risk of cardiovascular events. So we should directly continue to measures such as lifestyle measures to reduce blood pressure. And if that's does not meet the goal, then you have to initiate pharmacologic therapy. For those who are having 10-year cardiovascular risk of less than 5%, they don't warrant pharmacologic therapy, and we can just continue the lifestyle measures. So for those in between 5 to 10, we should look for other things, other risk modifiers. So we should look for other risk modifiers such as ethnicity, family history, retroviral infection, and the like. So if they have this, they're considered as being at high risk, and we'll proceed like that of the high risk with lifestyle measures, then pharmacologic therapy. And if they don't have this mentioned conditions, then we'll further look for other modifiers, sex-specific modifiers such as diabetes mellitus, gestational diabetes, gestational hypertension, preeclampsia, and the like. So this is how we approach patients with elevated blood pressure. So this is basically the same thing as the recommendation. So it's a class 1A recommendation to use a risk-based approach in the treatment of elevated blood pressure. And for those who don't have the mentioned risk factors such as moderate to severe CKD, established cardiovascular disease, hypertension-mediated organ damage, they should be scored. As I said, we can use score 2 for assessing the 10-year cardiovascular risk for individuals between 40 to 69, and for those above the age of 70, we can use the score 2 OP. And we also have other scores, especially for DM and the like. Okay. So what are the other cardiovascular risk factors? So there are modifiable risk factors and relatively fixed risk factors. So like cigarette smoking, including secondhand smoking, DM, dyslipidemia, hypertension, obesity, and physical inactivity are relatively modifiable risk factors, and family history, sex, and increased age are relatively fixed risk factors. So after categorizing, the second thing that we'll talk about is screening and blood pressure measurements. And screening and blood pressure measurement. So normally, screening is very important in conditions that are asymptomatic, like hypertension. So screening is very important in this type of condition. So we have different types of screening methods. So one is systemic screening, the other is opportunistic screening. So opportunistic screening basically means an individual will come to the clinic for a number of reasons, and as part of the physical examination, blood pressure would be measured, and they will either be found to have elevated, non-elevated, or hypertension range blood pressure. So that's opportunistic screening, and opportunistic screening is highly recommended. Okay. So the other is systemic screening. Systemic screening basically means we just select individuals based on their likelihood of having high risk for hypertension and CVD. So then we measure their blood pressure. So more evidence is needed before systemic screening programs for BP measurement can be recommended in all adults, but opportunistic screening is highly recommended. So in terms of blood pressure measurement, we have, as I said before, office blood pressure measurement and out-of-office blood pressure measurements, including home and ambulatory BP measurements. So opportunistic screening is for elevated BP and hypertension is recommended at least every 3 years for individuals below the age of 40, and annually for individuals above the age of 40. Whereas in individuals with elevated BP who do not currently meet the threshold for BP lowering therapy, risk assessment and BP measurement should be done at least annually. So it's a class 2A recommendation. So this is just a summary of how we screen for hypertension by office BP. Non-elevated, less than the age of 40, we can just screen every 3 years with opportunistic BP screening. Non-elevated, above the age of 40, we can do opportunistic BP screening at least once per year. Elevated BP, no high risk conditions, 10-year risk less than 10%, we can proceed with repeating the risk calculation and BP measurement yearly. For those who have high risk, first we have to confirm BP, blood pressure, preferably with the home or ambulatory BP measurement, similar to hypertension. And for those who are having a slightly higher or stage 1 or stage 2 hypertension, we should confirm BP urgently and promptly. Those who are having blood pressure more than 180 by 110, and we should evaluate and work up for hypertensive emergency. This is a similar recommendation. It's a class 1A recommendation for confirming hypertension, okay? So, okay, next, when we come to how to communicate the diagnosis with our patient. So I would say this is the difficult part. It needs skill and experience. So we have different types of patients. I wouldn't want to call them resistant patients, but there are some more than others who resist medication. So our communication skill should be good. So they will ask us questions about the illness, about the medication, about the consequence, the cause, the necessity for management. So as much as possible, we should try to address those questions. We should tell them about the disease, the illness, and based on their level of education, we should define the illness. So we should not assume level of education and understanding. So as much as possible in simple and understandable terms, we should define the disease. So we can follow the identity, control, timeline, consequence, and cause for illness representation. So for those who have basic education or who are educated, we can define blood pressure for them. And another question that they might ask is the illness controllable through medical intervention or behavioral changes? So we can tell them that hypertension is controlled with medication, and behavioral changes are also important. And the timeline also, it's very important also to address whether the condition is acute or chronic. So we should tell them the chronicity of the disease and that it requires long-term management as well. And the other is consequence. So first is our patients should understand about the disease, should understand about the consequence as well. So normally fear is not a great motivator of adherence or persistence. So we should not try to scare them about the disease, but tell them in frank terms, okay? So the other is they will also ask us about the cause of the condition. So we should tell them about the multifactorial nature of the disease, how there are modifiable risk factors and how there are non-modifiable risk factors such as genetics and age as well. And they might also ask us about concern, or they might also have concern about the medications. So we should reassure them about the possible benefit and side effects as well. So the third thing that we're going to discuss about is adherence and persistence. So first we should define what adherence is. So basically adherence is the extent to which an individual or a patient's behavior, let's say with respect to taking medications, coincides with the recommended way by a healthcare provider. So that's adherence. So adherence is usually suboptimal, especially in suboptimal, especially in asymptomatic conditions such as hypertension. Whereas persistence represents the amount of time from initiation of medication to discontinuation of therapy. So at every visit, we should check for adherence and as well as persistence, okay? And this is very important, especially in the case of resistant hypertension. So it's a class 2A recommendation, but we should have objective evaluation of adherence, especially in either by directly observing the treatment or checking the urine or blood samples. Okay, so having said this, what are the routinely recommended tests to do in all hypertensive patients? So all hypertensive patients should have at least fasting blood glucose, and if it is elevated, we should do hemoglobin A1C, and this is basically to assess for cardiovascular risk and comorbidities. Again, to assess CVD risk, we should also do lipid panel, total cholesterol, triglyceride, HDL level, and we should also do tests to screen for secondary hypertension, such as sodium level, potassium level, hemoglobin, hematocrit, and thyroid function test, TSH. And we should also assess for the serum creatinine and the GFR, urinalysis, urine to albumin creatinine ratio. This is basically to assess one for cardiovascular disease and two to look for hypertension mediated organ damage, as well as this will also guide us for treatment. So we'll see what are the contraindications to certain treatments and what drug works in what condition. And ECG is also required. Okay, so as part of assessing hypertension-mediated organ damage, and also to look for other conditions. So we'll come to the when we come to the treatment part, we'll see how certain medications are add-on or preferably added to underlying conditions. So ECG is important. So having said this, let's come to the actual procedural part of blood pressure measurement. So what is the right way of measuring blood pressure? So it should be in a quiet room. The patient should be comfortable in a comfortable temperature. So before blood pressure measurement, the patient should avoid at least for 30 minutes, avoid smoking, caffeine, and exercise. And at least the patient should sit and be relaxed for 3 to 5 minutes. And it's better for both the patient and the one who's measuring the blood pressure not to talk during the measurement. And the patient should, our patients or the individual should sit comfortably with their backs supported and with their feet uncrossed and touching the floor. And with regards to the device, we should obviously use a validated electronic device. And if we're using alternatively, we can use a calibrated auscultatory device. And other important thing is the cuff size, so size of the cuff according to the patient's arm circumference. And for manual auscultatory devices, the inflatable device should cover at least 75 to 100% of the individual's arm circumference. And with regards to the protocol, at each visit, we should take at least 3 measurements, 1 minute apart, and the average of the last 2 measurements should be taken. If the first BP reading is less than 130 by 85, no further management measurement is required. So this is just a picture illustrating how to take blood pressure appropriately. Back supported, arm at the level of the heart. The mid arm should be at the level of the heart. Cuff covering 75 to 100% of the individual's arm circumference. Validated electronic manual or auscultator. Patient seat is at the floor. And the other things that we talked about: no smoking, no coffee or exercise in 30 minutes, and patient should be relaxed for at least 3 to 5 minutes. Okay, so cuff size will depend on there are different types of cuff sizes. We have small adult cuff size, large adult cuff size, and adult thigh. Sometimes we can use for emaciated patients. We can measure in the lower extremity. So if we're using a tighter cuff, it might overestimate, and if we're using a loose cuff, it might underestimate our reading. So As I said before, you have home blood pressure measurement and ambulatory blood pressure measurement. So when we say home blood pressure measurement, it's the average of all BP readings done for at least 3 days and preferably for 6 to 7 consecutive days before each visit, and 2 measurements each visit, and each session should last 1 to 2 minutes. In ambulatory, usually it's a 24-hour reading, and devices programmed to keep on recording every 15 to 30 minutes, and it will provide both daytime and nighttime. So this is one of the advantage of ambulatory BP measurement, that it also measures nighttime and as well as 24-hour BP measurement. So these two out-office BP measurements have similar advantages. One is you can avoid both uh, so-called white count hypertension and also masked hypertension. So the advantage of ambulatory BP measurement is that it can identify white coat and masked hypertension, and it has a strong prognostic evidence, nighttime reading, and it can also give us additional information, including short-term BP variability. Disadvantage, obviously, it is expensive, needs experience, and can be uncomfortable. Whereas home BP measurement, actually easy to do, so can identify white coat and masked hypertension like that of ambulatory BP measurements, cheap, widely available. So currently there are different home care givers, so we can apply this, and measurement is at home setting, so the patient will be very relaxed than the office. So individuals, when their blood pressure is taken at the office, they tend to be anxious, and which might increase briefly their blood pressure level. Okay, so and the patient is also engaged in the BP measurement, so it would be part of patient-centered care, and we can easily repeat it on a day-to-day basis. And the disadvantage being no nighttime reading, and if done by inexperienced individuals, it can potentially have measurement error, and yeah, so that's how that is with regard to comparison of ambulatory BP measurement to that of home-based BP measurement. So now coming to the treatment and prevention part. So what is the goal of treating blood pressure? So the ultimate goal of treating blood pressure is, one, to decrease cardiovascular events and cardiovascular disease events. The second is to improve the quality of life, and lastly, to also prevent premature deaths. Okay, so we have two well-established strategies to lower blood pressure. One is lifestyle intervention, and the other is pharmacological therapy. So there are other device therapies which are still with still ongoing studies, but yet to be proven to be effective in treatment options. So for the time being, let's forget about that and focus on the lifestyle intervention and pharmacological treatment. So studies have shown that decreasing systolic blood pressure by 10 and diastolic by 5 can result in reduction in all major cardiovascular events by up to 20%, also decreases all-cause mortality, stroke, coronary events, and even heart failure by as much as 40%. So when we come to lifestyle changes, so what do we mean by lifestyle changes? So healthy lifestyle choices can prevent or delay onset of hypertension and also can reduce cardiovascular risk. So, but this should never delay the initiation of drug therapy. So individuals who are categorized as having hypertension and are requiring blood pressure measurement should be on pharmacological therapy. We should not delay initiation and just continue on lifestyle changes. Okay, so the major drawback with lifestyle changes is persistence. Okay, so poor persistence is the major drawback. So the other thing is that concurrently initiating lifestyle and pharmacologic therapy together. So the patients might get, when we start them together, patients might get the impression that lifestyle changes are less important, okay, less important, and the patients So in this situation, we should counsel our patients that the lifestyle changes may allow for subsequent discontinuation or down titration of their medication. So this can motivate our patients to continue the lifestyle changes when they are also on pharmacologic therapy. So after initiation of lifestyle changes like drug therapies, we should follow them frequently and at least 1 to 3 months and until we reach our blood pressure goal. So what are these lifestyle changes or non-pharmacologic interventions? A better term, okay. So we'll see each of this. We'll see dietary sodium, potassium intake, physical activity, inactivity, exercise, weight reduction, diets, alcohol, and smoking. So with regards to sodium, so there are many studies that have reported a dose-response association between high dietary sodium intake and cardiovascular events. So, other studies have shown that a reduction in sodium intake by like 2.5 gram per day is associated with a 20% reduction in up to 20% reduction in cardiovascular events among certain population. And this health benefit of sodium restriction is mainly linked and mediated largely by its BP lowering effect. So current recommendation is to strict daily sodium intake to 2 gram per day, okay, or less, 2 gram per day or less. So this means it's about 5 gram of salt or about a teaspoon of salt per day. So this is the current recommendation based on the Ethiopian Society of Cardiology. And another very important thing to consider is that our sodium intake is not just by the salt that we put in our food. So we should always give emphasis that large part of the daily sodium intake occurs because by means of sodium consumption through contained in processed foods. Okay, so this processed foods has preservatives, so large amount of sodium comes from this. So as much as possible, that's why processed foods are not recommended. And we can be a bit lenient. We can allow up to 4 gram, 2 to 4 gram in the general population, especially in those who are having non-elevated blood pressure. We can allow around 4 grams per day of sodium intake. The other is potassium. Okay, so optimal dietary potassium intake has been shown to have BP lowering effects at the same time is associated with lower cardiovascular risk. So what do we mean by optimal potassium intake? So optimal potassium intake is around 3.5 grams per day of sodium of dietary potassium. Another way of assessing this is to have a lower urine sodium to potassium ratio, which is a surrogate for reduced dietary sodium intake and an increased potassium intake. So we can check the urine sodium potassium ratio, which is not usually practiced, but it can tell us that the sodium intake is low and the potassium intake is optimal. So how can we supplement, or how can potassium supplementation can be achieved by one? We can substitute sodium using potassium enriched salts. So we can substitute sodium chloride by potassium chloride. So we can use 75% sodium chloride and 25% potassium chloride. Or we can increase our dietary potassium intake. So what are foods that are highly enriched with potassium include the basics that we know, like banana. So a medium-sized banana contains around 450 milligram of potassium. The other highly enriched food in potassium is spinach and avocados, which contain up to 840 to 710 milligrams per cup. So you can use this recommended foods. But at the same time, we have to keep in mind that excess potassium supplementation should not be encouraged. Okay, so especially in patients with chronic kidney disease. So we should restrict patients with chronic kidney disease to less than 2.4 gram per day of potassium. So the other important aspect of non-pharmacologic intervention for blood pressure, elevated blood pressure and hypertension is physical activity and exercise. So having like in patients with hypertension, if they have regular aerobic exercise, we can substantially lower their systolic blood pressure. So regular aerobic exercise can lower systolic blood pressure by up to 8 and diastolic blood pressure by up to 5. And we have different types of exercise. So we have this high intensity interval training, such as like sprinting, and we have also moderate continuous exercises. So they are more or less comparable in terms of their BP lowering benefits, but overall, high intensity interval training has better, has higher degree of achieving improvement, especially in physical fitness. And overall, in patients with hypertension, engaging in physical activity will reduce cardiovascular mortality compared to that of patients who have a sedentary type of lifestyle. So what's the amount of exercise that is recommended? So like based on previous recommendations, 150 minutes per week of moderate intensity aerobic exercise, which is about 30 minutes, 5 to 7 days per week, can be maintained. But there are different types of workout plans. An alternative is to have 75 minutes of vigorous intensity exercise per week over 3 days. And so all in all, physical activity and exercise should be highly encouraged. There's one contraindication to physical activity, which is rare, is that for patients who are having a resting blood pressure of more than 200 by 110, systolic 200 and diastolic by 110, it's a relative contraindication, especially for high intensity exercises. And when we come to weight reduction and diet, we can expect we can expect a decrement in blood pressure, systolic blood pressure up to 4 and diastolic up to 3.5 for every 5 kg body weight loss. Okay, so weight loss has a strong evidence for BP lowering. And when it comes to diet, so basically, through our practice, we mainly encourage salt restriction, but that's not enough, okay? So apart from salt restriction, even more than salt restriction, there are specific diets which are recommended, like Mediterranean diets and also the so-called DASH diet, which is dietary approach to stop hypertension, basically containing foods such as fruits, vegetables, are highly recommended for patients with hypertension to reduce their blood pressure as well as to have a reduction in CVD risk. So in general, combination of weight loss, exercise intervention, and low sodium intake are highly recommended. And then alcohol, coffee, and soft drinks. Alcohol, there is currently no safe limit of alcohol. So if possible, all in all, patients should stop drinking alcohol. If that's not possible, then we should not recommend, but we should limit, have an upper limit of drinking alcohol based on sex for males, certain amount, and for females, a certain amount. So around 100 grams per week of pure alcohol, less than that, if they're going to drink. Coffee, so coffee had its ups and downs through history, sometimes through time. So at one point, coffee was being recommended. At one point, then coffee was seen as causing or worsening hypertension. But current evidence, at the very least, coffee is not associated moderately. Moderately meaning around 2-3 cups of coffee per day is not associated with high risk of hypertension in the general population. So at least it is not associated with high risk of hypertension. In fact, higher coffee consumption may also be associated with a lower risk of incident in hypertension. So there are other contraindications, okay, but we should not tell our patients not to drink coffee per current guideline. We don't know what's going to happen in the subsequent guidelines, but per current guideline, coffee is not contraindicated. And soft drinks, all in all, sugar sweetened beverages and sugar consumption at the same time is not recommended. Not recommended, I mean, we should limit our sugar sweetened beverages which have high sugar content. Smoking is one of the most significant modifiable risk factors. So smoking affects both ambulatory BP by raising the daily BP measurement, and it's recommended that we advise our patients to stop smoking, but not just recommend or counsel to stop smoking, but we should also have more intensive interventions for them to stop smoking. Okay, might not be enough to just say you should stop smoking, but they might also need other interventions. So this is basically the class and the level of recommendation for what we just discussed in terms of the non-pharmacologic intervention. One thing I forgot is potassium intake we should also be cautious for patients who are also taking ACE inhibitors and spironolactone potassium sparing diuretics. We should be cautious about potassium intake. So it's just a diagram picture representation of physical activity and exercise, as we discussed, around 150 minutes per week, increase daily physical activity, avoid sedentary lifestyle. In terms of isometric resistant exercises, so previously it was believed that only this high intensity exercises had benefit in terms of BP lowering and cardiovascular events, but even the isometric resistant exercises such as lifting weights have their own benefits. So patients who are already doing this type of exercises should be encouraged to continue. This is also a picture showing the non-pharmacologic therapies. Increase potassium intake, increase physical activity, optimize weight, reduce table salt, no smoking, reduce if possible, and if possible, stop drinking alcohol altogether. And now we'll come to when to initiate pharmacologic blood pressure treatment. So we touched upon this, especially on the definition part, but just to make it clear and summarize it, non-elevated blood pressure, BP less than 120/70, no pharmacologic treatment, just lifestyle measures. So what is our target blood pressure? As we discussed previously, BP has a linear, and blood pressure has a linear relationship association with cardiovascular disease. So an individual with a blood pressure of 120 has better cardiovascular benefit than an individual with a blood pressure of 125. So that's why we don't like to use the terms normal, normotensive, and optimal. So it is because there is a linear relationship. And for those who are having elevated blood pressure, as I said before, we classify them into two groups: those requiring pharmacologic therapy on top of lifestyle measures, and those in whom lifestyle measures alone are enough. Okay. So this is based on the 10-year estimated cardiovascular risk. If they have more than 10% 10-year estimated cardiovascular risk and systolic blood pressure of 130 to 139, we will encourage them to start all the lifestyle measures that we discussed, and we'll assess them within 3 months. So that's when we expect improvement. So if there is no reduction in the blood pressure within 3 months, we should start them on pharmacologic therapy. Hypertension, we discussed before. So our goal would be the lower the better, with reasonable and tolerable drug. If they tolerate the pharmacologic therapy, so the lower the better. So our goal would be to maintain BP between less than 120/70 for those non-elevated, but for the others systolic between 120 229, and diastolic between 70 to 79. So this is basically what we talked about in adults with elevated blood pressure, less than 10%. Lifestyle measures is recommended, and similar. So it's a class 1A, 1B, and 1A recommendations. So finally, we'll come to the drug therapies, pharmacologic therapies in hypertension. So the major drug classes which have good evidence for BP reduction and cardiovascular prevention of cardiovascular events are the ACE inhibitors, the ARBs, the calcium channel blockers, the dihydropyridine calcium channel blockers, and the diuretics such as the thiazide and thiazide-like diuretics such as hydrochlorothiazide, and also beta blockers. So of these five, the first four are first-line options for starting hypertension treatment in the general population. So beta blockers, they are added preferentially in certain circumstances. So they are more of an add-on therapy for certain circumstances, like patients presenting with angina, we can add beta blockers. Patients with heart failure, we can add beta blockers. Patients with myocardial infarction, and if there are other conditions that warrant to control heart rate, we can add beta blocker. So why is the second question would be, why are beta blockers not first line drug? So beta blockers are less effective at preventing stroke, and they have a higher discontinuation rate because of their side effects. This is one reason that they are not part of the first line drugs. The other reason is that studies have shown that combining beta blockers with diuretics increased risk of new onset diabetes, and another reason that overall the effect of RAS blockers and calcium channel blockers on preventing progression of hypertension mediated organ damage appears to be superior to that of beta blockers. So beta blockers are inferior in preventing progression of hypertension mediated organ damage. And one of the first line drugs, which are thiazide and thiazide-like diuretics, they are not as efficacious as the other drugs, and they are less effective in patients with reduced ejection fraction. So probably better to avoid them in patients with end-stage renal disease and those with ejection fraction less than 45. So coming to the mentioned drugs and their contraindication, diuretics, they are contraindicated in patients with gout and hyperuricemia. So it might worsen gout arthritis, and other possible contraindications for diuretics include metabolic syndrome, glucose intolerance, hypercalcemia, and hypokalemia. So patients who develop gout while they are on thiazide diuretics, better to switch them to other medications which have even benefit for gout, such as the ARBs. We can give them valsartan and the like. So we should switch them to ARBs. And for beta blockers, asthma, high-grade AV block, and bradycardia are compelling contraindications. Other contraindications include metabolic syndrome, and beta blockers have also been shown to cause glucose intolerance, and there are also evidence to showing that they are also associated with sexual dysfunction as well. Calcium channel blockers, they can cause edema. They can might also worsen heart failure, especially class 3 and class 4 heart failure with reduced ejection fraction. The ACE inhibitors compelling contraindications include pregnancy, hyperkalemia, bilateral renal artery stenosis, and angioedema. And we should also avoid them in women with childbearing age because of their teratogenic effect. And for ARBs, similar to ACE inhibitors, pregnancy, hyperkalemia, and bilateral renal artery stenosis as a compelling contraindication. So finally, which do we prefer, monotherapy versus drug combination? So for those who have an indication for pharmacologic therapy. What are the benefits of upfront combination therapy? For which patient category do we recommend upfront combination therapy, and for which group of patients is monotherapy recommended in the first instance? So the benefit of combining drugs, especially on a single pill. So combination means starting two drugs from different class, or two or three drugs from different classes at low doses. Okay, so combining drugs from different drug classes can have additive or synergistic effect and lead to greater BP reduction than increasing the dose of one drug. And further benefit of combination therapy is because when we combine, we're using low doses, side effects will also be lower. And the other thing is we'll have a swifter and fast BP control, so which is very important for long-term adherence. So patients will have the swift BP control. The drawback of drug combination is that patients might have patients' level of response to individual BP lowering drugs might be heterogeneous. So one drug might work for certain individuals, and the other drugs might work for certain individuals. So this is the major drawback of combination therapy. So initiation of monotherapy. So monotherapy is recommended for individuals with elevated blood pressure. So for elevated blood pressure, we don't recommend giving combination therapy. The other is for frail patients, okay? So if they are moderate to severe frailty, better to restrict them to one therapy, and those with orthostatic hypotension. Sorry. Okay. Those with orthostatic hypotension, symptomatic orthostatic hypotension, and age more than 85 years, at first instant, monotherapy is recommended. So age by itself, it's not a good indicator of frailty, but we'll use a cutoff point of 85. Some individuals above the age of 90 are fit, but for the sake of discussion, for this group of patients, monotherapy is recommended. For the other, all currently drug combination is recommended. So we'll start them with low dose combination of either ACE inhibitors or ARBs with calcium channel blockers and diuretics. So we could not use ACE inhibitors. We don't use ACE inhibitors and ARBs together because of the side effects. So, but we can combine ARBs or ACE inhibitors with calcium channel blockers and diuretics. So currently they are available. We have them in our pharmacies. We have combination of ACE inhibitors with diuretics and the like. So after starting on combination therapy, we'll check whether blood pressure is controlled after 1 to 3 months. And if blood pressure is controlled, then we can just follow them yearly, at least yearly, at least every year. For those blood pressure not controlled with combination therapy, then we'll add one drug, and low dose triple combination therapy will be given. And again, if low dose combination triple therapy is controlling the blood pressure within 1 to 3 months, then we can just follow them at the very least every year. And if not, if patients' blood pressure is not controlled with triple therapy, then we will titrate the drugs to maximum tolerated triple combination therapy. So at every point, as I said before, if they have an indication for beta blockers, we can add beta blockers like angina, heart failure, myocardial infarction, and the like, okay? So if blood pressure is not controlled with maximally tolerated triple combination therapy, including ACE inhibitors or ARBs with calcium channel blockers or diuretics, then we should consider within 3 months, we should consider resistant hypertension, and we should work them up for resistant hypertension. And you can also add spirolactone, and before labeling them as resistant hypertension, we should also check for adherence. Like we mentioned before, we can check for the urine level or direct absorption of observing therapy. So, so this is all on monotherapy versus drug combination. Finally, when should our patients take their medication, their BP lowering drugs, timing of medication? So currently, they should basically they can take their medication at any time, but it should be persistent, okay? They should take their medication at similar times every day. Otherwise, there is no specific current recommendation, either morning or night. It's all the same as long as they persistently taking at the same time every day. And these are the recommendations that we discussed among all BP drugs, the ACE inhibitors, the ARBs, the calcium channel blockers, the thiazides are first line. And so combining ACE inhibitors to RAS blockers is not recommended. Spirolactone can be added as a fourth drug, especially in patients with resistant hypertension. And single pill combination is preferred for adherence and persistence. So this is just a diagram that we discussed upon, including screening, risk stratification, and treatment of patients with hypertension. So thank you very much, and now the floor is open for questions.
Yeah, thank you very much, Doc. It was a very interesting presentation, and participants have already started writing some questions in the chat box.
Okay.
There are a lot of questions, so we will be limiting the questions. Can you access the chat box, or should I read you the question?
Okay, I can access the chat box, okay?
Okay.
Okay, so the first question is what's the appropriate interval time between two BP records to diagnose hypertension? So if we're taking blood pressure measurement on a single episode, if we're taking three blood pressure measurement, they should be at least 1 to 3 minutes apart. If it is for confirmation, we can confirm within a month or 1 week. And are there any scenarios where we could diagnose hypertension with only one measurement besides hypertension crisis? So the measure is for patients with hypertension emergency. If they present, we can diagnose hypertension, as well as for patients presenting with hypertension mediated organ damage, we can diagnose hypertension. Okay, the second is a comment. Okay, the suggestion. Okay. Do you think that measurement recommendations specified are followed in our facilities? Yeah, so it depends on the facility, but all in all, our patients, especially the resting part, they might come right away and blood pressure might be measured. Sometimes they are in the sun, in the waiting area, it is noisy. There are many factors which can elevate the blood pressure. So I wouldn't say that the recommendations are currently being applied, especially in government hospitals and in high volume centers. So, okay. So white coat hypertension, so it is basically a raised blood pressure because of especially in office BP measurement. And so the way to confirm white coat hypertension is to have out of office BP measurement. White coat hypertension by itself is not a risk factor for cardiovascular events, okay? And just shows that patients might be anxious and the like. Yeah, so in terms of potassium content, Someone has mentioned it. Potatoes also have higher potassium content. So spinach has around 840. Mashed avocado cup has around 720. So in terms of pure potassium content, they have higher amounts. Yeah, the other question is, a single BP measurement more than 140 by 90, is it an indication to start pharmacologic management? So as the definition says, it has to be confirmed. Okay, a single BP measurement is not enough. It has to be confirmed. It has to be repeated, preferably in out of office measurement. If not, repeated office measurement in 1 to 3 months. So the other question that is, when is the exact time to start BP medications? When swinging BP measurement of high and low, and for around 1 year, considering side effects of medication. So the importance of labeling patients in the categorization is for this. Okay, so if you have, based on the appropriate BP measurement techniques, if you have blood pressure record of more than 140 by 90, and if it is confirmed, then the patient requires blood pressure BP lowering therapy. What if fully controlled with combined therapy after 1 year? So normally we can de-escalate, okay? So we can de-escalate medication, we can de-escalate starting from what drug they have been on for a longer time. You can start de-escalating measurement if it is within target, goal blood pressure. So what is the choice of drug? So we did not discuss on hypertension and other concomitant diseases, but what is the choice of drug in patients with CKD? So if the patient has already established CKD, especially proteinuric CKD, if it is proteinuric CKD, ACE inhibitors have anti-proteinuric effect. So for patients with proteinuric CKD, like DM nephropathy having proteinuria, ACE inhibitors are recommended. So in terms of manual or automated, I think we can use both, as long as so there are some recommendations that say they prefer using manual than automated, but for practical purposes we can use both manual or automated, and sometimes you can confirm one with the other. So we can use both as long as it is well calibrated device. So another interesting question is, does SGL2 have a place in hypertension management? So SGL2 inhibitors, GLP-1 agonists, the ARNIs, they are part of the new or medications that are currently undergoing studies. So pathophysiologically, it makes sense that SGL2 inhibitors will lower blood pressure. But as part of the management for just hypertension, there is no current recommendation to give SGL2 inhibitors just for hypertension. I mean, if they don't have other indications such as DM, or as part of the guideline directed treatment for heart failure for heart failure. So some of the questions have been answered by other audiences. So how do we proceed in a patient with echo evidence of hypertensive heart disease and LVH with normal blood pressure? So normally you don't expect patients, if the patient really does not have high blood pressure, hypertension, we don't expect them to have hypertensive heart disease or LVH. So this is one area where we should also look for masked hypertension or like muscular hypertension could be the cause, so we should have maybe check for ambulatory BP measurement or have a 24-hour BP measurement to make sure that the patient really does not have hypertension. In rural areas, they cannot measure their daily allowances for their daily allowances, for example, potassium, sodium intake. How can we measure it? And not just in rural areas, so we don't actually measure it. And I mean, if you're talking about serum, okay, I think it is important, and I mean, there is no way around it. So, I mean, it's the recommendation to have serum sodium, potassium as part of guiding treatment and looking for secondary causes. But I'm not sure on what to do if there are no laboratory availability. Okay, I think I've answered some of your questions.
Yeah. Yeah, thank you very much, Doctor. So, on behalf of Blue Ethiopia and all our participants, and also Lifeline at this home-based care, I would love to thank you for taking the time to present on the Blue Hills virtual seminars, and I hope we will be seeing you in the future with other topics as well. And if you have any last remarks, so let me give you the stage one more time and we can end the session today.
Okay, thank you everyone for joining the seminar. And hopefully, as you said, we'll have more webinars. So we did not touch on all aspects of hypertension, especially the acute hypertension urgencies and emergencies, and hopefully we'll have another session for those topics. Thank you.